Di record nih.
Udah dok, silakan.
Assalamualaikum warahmatullahi wabarakatuh. Good evening to all my fellow. Welcome to our webinar about the curing the pain. This is a webinar by BPRC Learning and also Pain Management Network. On Google Meet we have Dr. Dia Anita, Dr. Sakina, and Dr. Maisa. Hello doctor, and then on the Zoom meeting we have Dr. Adin, Dr. Dona Octaviani, Dr. Putri Hoirani, Dr. Lisa, Dr. Rita Winarti, Dr. Sabin, Dr. Stefanus. Hello doctor, and before we going to present the case, we have announcement first about the upcoming course by Pain Management Network. We have 3 upcoming courses. The first one is Pain Management course. This is held on the August until November, and the second one is IPM Ultrasound Guided Intervention on basic and also intermediate course. This is the 3-month learning program held on August until November for the intermediate. And now I will introduce for the presentator. This is Dr. Novy. Hello, doctor.
Halo, Dr. Vita.
Now we want to talk about the curing about the pain, doc.
Okay.
We have a lot of cases. I think I will check for the first one. This is the first one. You can start for the presentation.
Okay. Hi everybody. Good evening, good morning, good afternoon, wherever you are, because we are not here from Indonesia yet, but then the recording will be distributed around the world. And maybe somebody from outside Indonesia is already here also. Hi. I want to share several cases, a lot of cases actually, but probably we can only share 2 or 3 cases for the moment. But I'm sure that we are all dealing with a lot of pain cases that, as we all know, some can be treated, some cannot be treated, some can be treated but we don't know how to treat it, some we don't know because the knowledge from the medical staff hasn't yet come to the cure. But for the curable ones, actually we must be able to do it. But it depends on our knowledge, it depends on our skills. What I'm going to share is some of the cases that very commonly found in our daily practices. By sharing this, I hope we can have a broadened point of view on how we treat our pain patients. Whether you are orthopedist, whether you are neurologist, whether you are physiatrist or anesthetist or even general practitioners, I hope that we will have the same point of view, whether you are going to treat it using my way or your way, but at least the pain is cured. Okay, but first I want to state again that we cannot treat our patient, either it is pain patients or other diseases, if we cannot know the diagnosis. We cannot treat our patients well if we don't know how to assess the patients? How can we treat our patients if we cannot take the history taking well, we cannot examine our patient well, we cannot make the supporting examination as needed, and then how can we cure our patients by not knowing a lot of things that we should know? Okay, I'm not intending to tell you what to do, but let's start with the cases, so then we will maybe have another point of view. Okay, the first case is a case of a 94 years old young lady, lives in Bandung. She is a nurse. Her education is D3. What is D3? Academic diploma. She's Muslim, she's Indonesian, she's not married yet, and the vital sign is within normal limit, and her functional status is independent. This is for the identity. The chief complaint of this patient was pain at upper back since 2 weeks ago, since 2 weeks when she came to me. But the symptom was on and off since 2 years back. Okay, the numerating rating scale was 4 to 5 from the 10 pain scale. There's tingling sensations on and off, but no numbness. And there was referred pain to the neck and head. So try to imagine what the appearance of these patients should be. Okay, the pain was on and off, and the pain was reduced when she took a rest. There's another thing, that the pain was increased. Sorry, this is the last PPT. The pain was increased when she did the daily activities. She is a nurse working at a clinic. Okay, then there is no history of allergy actually. The allergy written here is allergy to needle is found afterwards. Okay, and the history of past illness, she got gastritis, history of drugs consumed. She has already taken paracetamol 500 milligrams for a week. So then, from this history taking, what is the differential diagnosis? If you want to talk or if you want to text, please feel free to do that so we can have interaction, not only me talking to you. Is there anybody willing to say something? Please feel free, okay? The first differential diagnosis is because there's tingling sensation, although there's no numbness. For me, it was radiculopathy, cervical radiculopathy. Are you agree with me or not? Okay. The second one is Myofacial trigger point syndrome, or MTPS, because she suffered from upper back and neck pain. The most commonly seen in my clinic cases is Myofacial trigger point syndrome. Okay, actually there is tenderness at the right upper back and right paravertebral cervical, and at the occipital protuberance at the left and the right side. And there's also nodule at the right upper back and the right paravertebral cervical area. Spasm also was felt there, and there's referred pain. When I touched the nodule, then the pain was referred to the neck and to the hand. That's for the local tenderness. And then I do the head compression test. The head compression test was negative, and the distraction test was negative also, and the swelling test was negative. So, from this physical examination, the previous slide that I have two differential diagnoses, right? Radiculopathy cervical and myofacial trigger point syndrome. So then from this physical examination, then I have the, hopefully have the diagnosis, okay? From the spooling test, from the distraction test and compression test, I ruled out already the cervical radiculopathy. So I have now the myofacial trigger point syndrome. Okay, but then there is a local tenderness at the occipital protuberance. So I think of right greater occipital nerve entrapment there, because sometimes the patients also complain of headache when she has the back and neck pain. Okay, so then from this diagnosis, I have problems. The problems were, the first was pain, and the second is vocational, because then when the pain is felt more, it disturbs the working of this patient. So it disturbs the work of the patients. So my goals were, the first, pain reduction. By doing the pain reduction, I hope I can increase the quality of life of this patient. Okay, because by doing better while working means that the quality of life of this patient will be increased. So my management is, the first is, while I examined her, I've already known that the first difference diagnosis is the myofacial trigger point syndrome, and because the numeric rating scale is 4 till 5, I try to stress her by giving her stretching exercise. So what I did is ask her to do the stretching exercise. I asked her to do the flexion, the extension, lateral bend to the left and to the right, and rotation to the left and to the right, but plus stretch. Okay, after do one round of that stretching, the pain was reduced. So then what I think that this is a simple case, because maybe by giving her only the stretching exercise, the pain will be gone. But then we must remember that when the numeric rating scale is 4 to 5, means actually we cannot give too much exercise to our patient. So what I did is give her dry needling. Dry needling is putting needles to certain points of the body of the patients, hoping that by inserting the needle, the muscle spasm will be reduced. If there's time, I can show you that how the dry needling works. By inserting the needle, if we touch our back here, if we feel spasm, we can rub it, we can massage it a bit, okay? Then we will feel better. Why? Because by doing so, we reduce the tension of the muscles. And while we do the reducing the tension of the muscle, we give also a relaxing sensation. Because then, by doing so, our brain will produce endorphin. Endorphin is a kind of morphine that is naturally produced when our body have a stimulus such as needling or massage, or when we do exercises. So I hope by giving dry needling, then the muscle tension will reduce, the muscle spasm will reduce, the endorphin will be produced, so then the pain will be reduced or even diminished, and then the muscle will be relaxed, then the patient will be cured. So then I give this patient dry needling. Right after the dry needling, the numeric rating scale reduced till 1 to 2/10. So that's good, right? It's time to start whatever exercise that we want to give to our patients when the numeric rating scale already less than 3. So then what I do next is I give her stretching exercise. The stretching exercise is really simple, just like I told you before, doing flexion, extension, lateral bend to the right side, rotation to the left and to the right side, but plus by doing the stretching. Okay, after 5 rounds, the numeric rating scale becomes 0. So then I don't have to give this patient any medication, no medication at all, but I give her proper body mechanic. Why? Because as a nurse, she regularly have to do the paperwork, means that she has to bend her neck forward, do the typing, do the cleaning, do the tidying of the desk. That makes the head bend forward, means that yang lumbar, means that the load, bukan yang lumbar, the load of the neck muscles become increasing. Okay, this is mannequin. The weight is more or less 3 kilograms. Suppose this is our head weighs more or less 3 to 5 kilograms, right? So if Dr. Vita, could you please help me put it in front of your body, okay, with using your right hand like this, okay? Is it heavy? No, hang it like this. Okay.
Yes.
Is it heavy? Okay. So now try to put the mannequin in front of you like this. Okay. What do you feel? Heavier. Why? Because the axis now become longer to your body axis. Okay. Hold it for a moment. Okay. How many seconds can you handle it? Okay. I will see at the clock. Okay. The clock is tick. Okay. So now, have you already felt uncomfortable? Yeah. Shaking. Okay. Okay, you can put it back. Okay, see, that's what happened to our neck if we frequently do the forward bending of our neck. If Dr. Vita can do the placement of the mannequin for 10 seconds here, how about our neck muscles here? Our neck muscles only small muscle compared to the arm muscle. So then, if the nurse does the desk stuff for longer period, imagine what happened to the neck muscles. It will get tired, it will get overload, so then there will be uncomfortable sensation, and if it is done for longer period, there will be pain. So by giving the patient proper body mechanic, how to do the daily activity, how to work ergonomically, I hope that the pain will not come too soon, and hopefully it will not come back again. Okay, so then I give the patient how to deal with the daily work, how to deal with the paperwork, how to deal if then she has to overcome the load of the work without to have too much unnecessary pain. Okay, so then after 1 week time, the patient comes back, there is no more pain. Of course, by the patient having the proper body mechanic, then daily stretching of the neck muscles. Okay, this is actually quite simple case, but not always like this, because since the working from home period when we have COVID time means that it's already 4 months, the upper back and neck pain patients increasing in my clinic. Although they don't work as hard as usual, but we do a lot of texting, typing, watching the movie, using the laptop with the not proper body mechanics. So for ourselves also, I believe, including me, we frequently do our daily activity not ergonomically. Let's do it for ourselves so we can educate our patients also to not having a lot of upper back and neck pain. But then if the patients come to us, we know how to treat them. Okay, this is a simple case that is simply cured using drenaling and stretching only. But a lot of cases need medication, oral medication, and a lot of cases needs also interventional pain management using ultrasound guidance. Okay, this is the first case. I will proceed to the second case. This slides is a slide about Myofacial trigger point syndrome. I don't want to discuss about it, but if there is still time, I will go back to these slides, okay? This is Myofacial trigger point syndrome, what is the etiology and the reference, okay? I prefer to go to the next case. Okay.
Anyone want to ask Dr. Novy, you can chat or speak on the Google Meet or the Zoom meeting.
Okay, but maybe you want to talk also. Okay.
Now for the
Okay.
I want the announcement again. This is the upcoming course by the Pain Management Network. The first one is the Pain Management course. It can be attended for all of the physicians, for the general practitioner also. It will help on August and until November. And then the second one is the Basic Ultrasound Guided Interventional Pain Management. This for the specialists who want to do the interventional pain management. It occurred in August until October, and then for the intermediate, for the nurse, it for September until November. And then we go to the next page. The next case.
Okay, thank you. The next case, I don't want to say that the first case is a simple case, but if you don't know how to treat, it's not simple. Okay, this second case maybe for you is also a simple case, but for me not simple also. This case is about 80 years old man, an old man who lives in Bandung. He has already retired, of course, because he is 80 years old. He is a bachelor. He is a Christian. He is an Indonesian and married. His vital signs were within normal limit, and his functional status is independent. This is a fresh case. The chief complaint was pain at lower back since 1 month ago. The pain was felt when going to sleep and at early morning when the patient is going to wake up. The numerating rating scale was only 1 until 3. Okay. But there is a but. The pain was referred to the right femur, to the right thigh. Okay. So just think of it. Okay. The pain was on and off. Means that maybe for you it's nothing, right? There's no tingling sensation, there's no numbness, but there's stiffness at the back. And there were also swollen at both feet. Mobilization was disturbed because of the pain. Okay, so from the history taking, there's another history of drugs allergy, nothing. History of past illness, there's gout and cardiac disease. The patient has already undergone coronary artery bypass graft at 2001. And history of drugs consumed, spironolactone, clopidogrel, bisoprolol, Uresic, Cangitins, and Hemobion. Okay. The differential diagnosis. The differential diagnosis is facet arthropathy. Facet arthropathy? Okay, facet arthropathy means that the backbone joints is inflamed, okay, and painful. Okay, but from the examination, I found that the patients also complaining of, so I jump to the physical examination, okay. The patient came using cane, okay, but the gait was normal. The patient can walk 5 times 3 meters without shortness of breath. I examined him like this because the patient is suffering from cardiac disease previously. The balance was slightly impaired. Okay, at the back there's pain at extension, more than on flexion, more on the right lateral rotation, like this, and more on the right lateral bending, and felt at the right paravertebral lumbal area. Okay, there's no pain when changing position, means that when the patient standing from sitting to standing, standing to walking, there's no pain. Okay, and there's no pain when the patient's lying supine to side lying to the left or to the right and to prone positions. But there's tenderness at the lateral facet at the level of L1-2 and L2-3. Okay. So then, the patients, by looking at the gait, I examine the patient knee. The knees are slightly swollen, so I examine for the knee, and the knee is slightly inflamed. There's a slightly increase in the temperature, and there's crepitation, both knees. So then I ask the patient to do ultrasound examination. Okay, from the ultrasound examination, I found suprapatellar effusion more at the right side than the left side. So then I come to the previous differential diagnosis that there is facet arthropathy and knee osteoarthritis with or without suprapatellar bursitis, pes anserinine bursitis, maybe ligamentous inflammation also, medial or lateral. Okay, so then I go back to the slide after the ultrasound examination. Then the diagnosis become facet arthropathy. The level could be L1, L2, or L2, L3 bilateral, although the pain was felt more at the right side. And then knee osteoarthritis bilateral with suprapatellar effusion more at the right side than the left side. Okay. So then the problems were, the first was pain, and the second is avocational because this patient has already retired. So then the goals were pain reduction and increasing again quality of life. Okay, if you have another way of thinking, please feel free to text. Okay, the management at that time is I do aspiration from the suprapatellar recess from the right knee, and I got 5 cc of aspirate. The color was yellowish, and then I give 30 milligram steroid triamcinolone into the right suprapatellar recess. I did this using ultrasound guidance, so I do the interventional pain management. Right after the interventional pain management, the numeric rating scale for the right knee become 0 until 1, and the left knee become 0. Okay, and afterwards I gave the patient paracetamol and tramadol. Then I order X-ray examination for the knee and lower back because I thought at that time maybe I have to treat the lower back also after I treat the knee, and I need also the X-ray examination to know the degree of the severance of the knee OA from this patient, and the evolution time is 1 week. Okay, on 1 week follow-up, there were no more pain at both knee, but the pain feel achy at the right calf. Then there was no tingling, no numbness sensation. From the knee X-ray, no knee osteoarthritis. Okay, no knee osteoarthritis, but there is knee effusion. Okay, so there's no correlation between the ultrasound and the X-ray. And at the lower back, there's no osteoarthritis also, but it is said spondyloarthritis. Spondylosis. Spondylosis means arthritis. Okay. And then I recheck the physical examination. From the physical examination, the gait was normal. At the back, normal pain. Magic, right? There's no tenderness at the lateral facet. This is the X-ray. You can see here. Have a look. This is the ilium, right? The right ilium. This is R. This is right side. This is left side ilium. This is symphysis pubis. This is sacrum. Okay. This is L5, L4, L3, L2, L1, and then to the thoracic vertebrae. We can see here that the patient has a lot of osteophytes here, and even the osteophytes combining from level to level of the vertebrae means that he is going to have ankylosing spondylitis. Okay. This is from the AP view, and this is from the lateral view. You can see also that this is the sacrum, okay, and this is the L5, L4, L3, 2, 1, etc. And we can see the osteophyte here is so big, and it is bridging to one another. Okay, so by looking at this X-ray, we can have the insight that how the pain comes in the lower back, because then the movement of the back is not smooth anymore and even becomes stiff. Because if this is my lower back here, okay, this is my lower back, this is the L5, L4, L3, 2, 1. You see here, this is the disc, right? The disc. We have nothing in between the vertebrae. Nothing. From the lateral view also, we have nothing. No bones, only disc. But in this patient, the osteophyte is so big, then the bones seem to bridge. The osteophyte seems to bridge the vertebral bones. So then how can he bend forward or bend backward without giving pain? And when the patient has already sleeping for a certain time or sitting for a certain time, when he gets up, of course, then the back will be stiff. Without talking about the facet arthropathy itself. Okay, this is the knee. It is said that there's no knee osteoarthritis. If there is orthopedics or radiologists, you can help me to read this X-ray. For me, this X-ray already means that the patient has knee osteoarthritis because the surface of the cartilage is already sclerotic. At least this is that one. Okay, yeah, osteophyte here. I see osteophyte here. Okay, here, lateral side. Okay, you see here, osteophyte, right? Okay, so if it is said that there's no knee osteoarthritis, maybe the radiologist wrongly taken it. Okay, you can see here osteopathy, enthesopathy. Okay, we can see here this is the shadow of the quadricep muscle tendon, and then it will goes above the patellar bone and insert into the tibial tuberosity. It is sclerotic, right? This is the tibial plate, sclerotic also. And this is calcification at the back of the knee joint. Okay. And then I re-examine the ultrasound. This is my workup for each of a patient that has already undergone knee joint aspiration. I found effusion again at the right suprapatellar recess, more than left but less than previous. And because there's no pain, I proceed to the diagnosis to proceed to the next treatment. The diagnosis becomes facet arthropathy, lateral facet arthropathy at the lumbar side but without symptom, and bilateral knee osteoarthritis with suprapatellar effusion more at the right side than the left side. And the management, of course, because then the fluid collection comes back again in 1 week time, I educate the patient to reduce the standing and walking, although after each aspiration, after each treatment to the knee, I always ask the patient to do rest for 1 day, and in 1 week time before he comes back to me, I will ask them to not to give the part of the body that is aching. For example, in this case, knee. Do not give the knee too much load. Means that don't walk too much, don't stand too long, and don't climb stairs. Do not squat, something like that. So then, in 1 week time, I can evaluate that whether the daily activities will make more burden to the knee. In 1 week time, there's fluid collection again, so I ask the patient to restrict the standing and walking more than before. And then I give hyaluronic acid injection to the both knee bilaterally using ultrasound guidance also. And then again, the paracetamol and tramadol is given only to reduce the pain caused by the needle inserted when I do the interventional pain management. And then I give vitamin, whatever you want to give. This is just the brand, okay? At the time, the patient came back with lab that I saw that he has urinary tract infection, so I gave him Sanprima is Cotrimoxazole, okay, Cotrimoxazole, and I programmed this patient to be evaluated in 1 week time. Okay, on 1 week follow-up after the hyaluronic acid injection, ultrasound guided, the ache at both calf has already reduced on and off, and from physical examination, the patient told me that he lost 23 kilograms of body weight because of thinking of pain. It must be worked up just in case something is going on, okay? But this is for next plan. The gait was normal. At the back, normal pain. The patient can sit, stand, walk without pain. From the urine analysis, there's still cotton but no bacteria. The ultrasound, there's effusion at the right, suprapatellar more at the left side. And so back to the previous diagnosis that we have facet arthropathy and knee osteoarthritis. Then now the diagnosis is still facet arthropathy and knee osteoarthritis, but without symptoms. Okay. Although there was suprapatellar effusion at the left and the right side. Okay. So then the management is education. I gave the patient quadriceps strengthening exercise, and then proper body mechanics. Proper body mechanics mean that the patient has to maintain the body mechanic, so then the lower back pain and the knee pain will not come back forever, if probable. Okay, proper footwear. Why? Because once we have knee OA, we must treat our foot well, because by doing so, we hope that the knee will be maintained better than if we not use the proper footwear. And then I give the flexibility exercise for the lower back and abdominal strengthening exercise for the lower back. And I gave the patient cane on the left side because the fluid collection is more on the right side and then at the left side. And the medication was stopped. The antibiotic and the vitamin can be continued by the patient and evolution in 1 week time. Okay, so from the two cases, I want to show you that pain can cause a lot of trouble. The pain can cause us lack of sleep, cannot work well, cannot think well, cannot do bathing well, cannot walk properly, cannot write, cannot even typing, cannot talk. Okay, so for all the happiness men can gain is not the pleasure, but in the rest from pain. This is said by John Dryden. Okay, the next slide is about the treatment of pain. From the first case, actually, I've shown you that the nurse can get rid of pain by simply doing exercise. Means it is non-pharmacological method. Non-pharmacological method means that it is rehab. I'm rehab doctor, so I do a lot of rehab treatment, including exercise, including giving modalities such as TENS, laser, ultrasound, not ultrasound for doing the intervention, but ultrasound to treat the pain. And then shortwave or shockwave therapy, all that is non-pharmacological method. For patients means rest and exercise. Okay? Then, if the pain cannot be reduced by giving non-pharmacological method, we must think of medical-mental treatment. This is the World Health Organization step-ladder treatment of pain. The second step is giving the patient NSAIDs, non-opioids. If the pain then diminished or healed, then we stop here. But then remember to still giving the patient the rehab. Okay? If the pain is still there, we must think about giving weak opioids, combining with the first step, and still giving the non-pharmacological methods. If then the pain is healed, we stop here, but we give the patient education, we give the prevention, we give the promotion treatment, so then the pain will not come back, or will not come back too soon. If then the pain is still there, we can give strong opioids. We can combine the first, the second, and the third stage together all at once, but remember to give also the non-pharmacological methods. Since the beginning till the end, there's always non-pharmacological methods. Not because I am rehab, but yeah, the patients need it. Okay, so maybe the patient needs operation. For example, there's bone fracture or tendon rupture, or maybe the patient suffering from cauda equina that needs immediate operation. Don't hesitate to refer our patient to the orthopedist or to the brain surgeon or to the surgeon, so then they can help the patient get rid of the pain without we delay them by giving the zero, the first, the second, and the third steps. But of course, if then the operation is not indicated or the pain cannot be treated by giving operation, means that what can we do? I've shown you from the second case that I give the patient interventional pain management. Interventional pain management is a filler that fills the gaps between these non-pharmacological methods and the pharmacological methods and the operation, if it cannot be done, so then the pain can be resolved, means that the patient will recover from the pain. From the zero until the recovery step, we still need the non-pharmacological methods. The patient has to know about how to treat their body, how to do the prevention, how to do the exercise, how to do the promotion treatment, Okay, so then the pain will be happy, the patient is happy, I am happy, and you will be happy, I believe. Okay, so then the summary, we will talk a lot of education to the patient. How can we educate the patient if we don't know? We don't know the knowledge, we don't know the skill to treat the pain. Means that we must know the diagnosis, and then we must know the diagnosis again. It's all about the diagnosis. And then we must know again about the diagnosis. All about diagnosis. So this slide may be about diagnosis. No. And then the next slide, the next statement is do not treat the picture. We see the second case that the patient has severe spondylosis, means severe facet arthropathy here with ankylosing spine, but I don't give him anything. I don't give injection, I don't give medication to treat the pain at the back. I only treat the knee. I treat the knee, and then the pain dissolve at the back. It's not because that I treat the back, but then it's a biomechanical linkage between the knee and the back. If the knee is treated, then the back is cured, it's good. But then if the knee treated, then the pain at the back is still there. We must treat the pain at the back, but not at all at once. We need to treat the knee and the back. It's not the way we treat it, one by one, step by step. So then we will save the patient from getting too many medication to their body, and then we save the money of our patients also, right? And then means that we give the patient chance to live healthier by not taking too much medication. But if then the medication is needed, don't hesitate to do it, either by giving oral medication or by doing injection, or even if the patient needs to be operated, don't hesitate to refer the patients to the surgeons. Okay, but please do not treat the picture. Even the ultrasound, you see that the ultrasound finding there's still fluid collection. What I do aspiration again? No. Okay, but give the patients proper body mechanics, and give the patient also exercise to strengthen the quadriceps muscle at the knee, so then the strength of the muscle will help the knee pain, means then the fluid collection will not come back too soon. Okay, and then case by case is different. At that old man, I give no re-aspiration, but from another case, if there's still time, okay, I will show you another case. The treatment should be tailor-made. Okay, means that I have 10 knee OA cases, the treatment can be different. Okay, and we must see the step-ladder pain management, whether we use the 0 stage, or the first stage, or the second stage, or the operation stage, or the interventional stage. I will not say that interventional pain management is the best. I will not say that rehab management is the best. And it cannot be said also that medicamentouse treatment is the best or the operation is the best, but we must think the whole problems as a whole, so we can treat the patient holistically. And don't forget to give preventive and promotive management for our pain patients. IPM is not panacea. Every step of pain intervention is a part of holistic rehabilitation program. For you, if you are neurologic, as holistic neurologic program. If you are orthopedist, as holistic orthopedics program. But talking about pain, a holistic pain program. Okay? And what we have to do is to repair, restore, and rebuild our patient. Okay, thank you. If there is question, now is time or question?
And also on the Zoom. I want to ask.
Okay.
How about the
Numeric rating scale. Numeric rating scale.
rating scale with the pharmacological management? Can we, if the patient have the NRS3, so we can give the patient steroid or
Very challenging questions, because the pain patients, especially the chronic pain patients, will come to you with, I am still having the pain. What you did last time is not curing my pain. At first time, I feel what I did, okay? But after the first, the second, the 10th, the 100th patient, then I know, oh, if I have the pain such as them, maybe I will think the same. I want to get rid of the pain totally. So then, when the pain is still there, then the patients will show you, can you treat me or not? Something like that. Okay? So, what we should do is make sure that the pain is still there. Very frequently, the pain is not there anymore, but the pain is still felt by the patient because the patient still feel uncomfortable. Okay, so then I simply ask the patient usually, is this pain or in bahasa pegel or uncomfortable, or you feel like you are stressed or something different? Then the patient will say, it's still painful. Okay, so then the next step is make sure that the pain is still there by doing the examination. For example, for the neck, upper back, and neck pain. Okay, ask the patient to do the movement. Is still any pain? The pain will be honest to you. No pain or still pain, or it is stress. Okay, if it's stress, means it's not pain. Okay, then if the pain is still there, for example, if I bend my neck to the left side, the pain is felt here. Okay, done. Then go back to the center. Is the pain still there? If the pain is not there, means that the pain is only, the scale is only 1 or 2, because the pain is already no more now. So then, if the pain is still there, when the movement is stopped, means that it's more than 3. Then we must do the provocation test. Okay, if then the provocation test exaggerates the pain, then we must think that the pain should be treated. But if the pain is normal when we examine him, then usually I don't give medication. But then the patient will say, Doc, now there's no pain, but later on, in 1 hour time, the pain will be there. If I sit for too long, for example, the pain will be there. Okay, so if you are already treated for 1 week time, okay, then the pain is there after you sit for 1 hour. But previously, how many hours you can sit? No, I cannot sit at a time. So then there's improvement, right? I usually give example to the patient. For example, you has typhoid for 1 month, and then after you are said, okay, you are free from your typhoid, you are healed now, you are cured, you can go back home. Can you run? No. So the patient needs to be patient to get back to the usual pace that he used to have previously. Means that the patient needs time to get back to the previous state. So this is our job, to give education that you are rehab, so you can do it better than neurologists and orthopedists. So if you are neurologist, if you are orthopedist, please send the patient to the rehab, so then the rehab doctor will rehab the patients better than you, because I believe that we have a lot of patients, we don't have time to talk a lot to our patients. Better than we give medication. Do not give medication. Just give education, then adjust the patient ability to do activity, adjust the patient ability to do exercise, step by step. So then at 1 week, 2 week time, or maybe 1 month time even, let them do it, but without medication. The exercise also must be given step by step also. Okay.
Dr. Sakina.
Hi, Dr. Sakina. Hi.
You want to ask something? You can talk, Dr. Sakina.
Waduh, so long.
In the second case, the main problem is lower back pain to femur. Despite there were any effusion at the suprapatellar, why piriformis syndrome a differential diagnosis for the lower back pain problem?
Good.
Then for the effusion, which always increasing after treatment, even after decreasing activity. Was there any possible pathophysiology that because of simple ankylosing in vertebrae will cause stiff in vertebrae and then will cause muscle spasm until the lower back? So it will affect the muscle at the quadricep muscle, and then it cause the fluid compensation to the knee.
Wow. Are you rehab? Are you neurologist? Wow. But okay, that's very good, Dr. Sakina. The first one, can I pull this closer to me? Okay. Dr. Sakina, ask us, ask you also. Okay, please feel free to comment. Okay. In the second case, the main problem is lower back pain to femur. Despite there were any effusion at the suprapatellar, why piriformis syndrome not becoming a differential diagnosis? Okay, to come to differential diagnosis, I actually examine the whole lower back. I don't type it the whole examination there at the slides, but for the lower back, I examine all. I examine the movement while the patient was standing. I examine him backward, forward, lateral bend to the left, to the right, rotate to the left and to the right, and it's all painful. Oh no, I can't remember. To the right side maybe, okay? And then, after doing so, I ask the patient to lay down at the back. I ask the patient to move to the left, supine, to the right, and prone. By doing so, I will know which structure may be related to the pain. Okay, at that time, I already think about, I agree with you, I think about the piriformis, I'm thinking about the sacroiliac joint problem, I was thinking also about the facet problems, I was thinking also about the radiculopathy actually, although there's no numbness, no tingling sensation, but for patients, I always include all that in my examination, then I will have exclusion afterwards. Okay, and then I do palpation. There's no local tenderness at the piriformis, no local tenderness at the sacroiliac joint, there's no local tenderness at the muscle at the paravertebral lumbar muscles, and there's no local tenderness at the hamstring, origo, there's no local tenderness at the greater trochanter, and when I move the patient, the slight leg bracing test were negative both sides, and then the Patrick, contrapatrick test were negative, and the piriformis test also negative. Okay, so by all sorting out exclusion criteria that is not included in the differential diagnosis, I exclude the piriformis. So that's how I work. The piriformis is not the differential diagnosis for this patient. Okay, and then after I treat the knee, after the 1 week time evaluation, there was no more pain at the back, right? So even the piriformis, since the first time, is not my differential diagnosis, and it is proved at the second visit, there's no pain, no more pain at the second visit. Okay, and 4, Dr. Sakina say, but you're very good, you're very smart, you're testing me. And the second question, then, for the effusion, which always increasing after treatment, even after decreasing activities, was there any possibility pathophysiology that because of ankylosing in vertebrae, causing stiffness in the vertebrae, causing muscle spasm until the lower back? Sure. Affect muscle at the, but the fluid collection is not too much. I think it's because of the weaken of the quadriceps muscles. Okay, so I give the patient quadriceps strengthening exercise. Although if you ask about other pathology, it can be other pathology. It can be because of synovial hypertrophy. I must re-evaluate my ultrasound image, because if there's synovial hypertrophy, the synovial hypertrophy will cause fluid collection again and again, especially if the patient cannot restrict the overloading of the knee. Okay, yeah, it must be re-evaluate in longer period. Okay, thank you, Dr. Sakina, for the very good question and suggestion for the differential diagnosis. Please, Araso. Okay, Dr. Lita, hi. Prof. Fauzia. Okay, if there still any question? Okay. Okay, if somebody wants to talk, please feel free to talk. Okay, just unmute your microphone. Okay, or you want to ask? Okay.
About the draining, there is the type of draining.
Yeah, about the draining. My draining technique is quite different from others, because I combine it with acupuncture actually. If we have time in the future, I will show you how the needle affects our muscles. If we have spasm, if we have trigger point of our upper back, I have the slide actually, but I must search for it. The appearance at the ultrasound will be like this. The normal muscles will be flat like this, but if it is so tight, then the muscle will be contracted like this, and the appearance will be like hills, like mountain. Okay, it's bumpy. So then, if I put the ultrasound right above the nodule, you can say it as nodule, then if we press it means as if we do massage, then the nodules, the bumpy, will become flattened. That's how it works, how the needling works. But the needle is more straightforward than the mechanical pressure on the nodule. So, under the ultrasound, we can see that once the needle inserted into the muscles, then the bumpy muscles become flattened. So, without having to insert and withdraw nodular insert technique, it's called the destroying the nodules. I don't have to do that, just insert the nodule at the trigger point, done, but I add some point of acupuncture points, so then the treatment will be more useful without causing unnecessary pain for me, unnecessary pain by inserting the needle again and again and again. And I use the acupuncture needle, the 0.25, so it's quite thin, not the 27, not the 25 gauge needle. Okay, only that, put at several trigger points. It's called local points in acupuncture. The local, so at any muscle spasm you can insert the needle. So if you're a GP, if you're a general practitioner, don't be afraid of putting needle at the trigger points. But remember, at the upper back, below the muscles, there is pleura. Be careful, do not insert the needle too deep. Okay, in skinny patients, the 2 centimeter depth will already put the needle into the pleura, so be careful. Okay, if you are acupuncturist, if one of you is acupuncturist, you can already know how deep the needle should be inserted without having the patient, without giving the patient any harm. Okay, because once the needle comes into the pleura, means we are going to give the patient pneumothorax. Okay, but more or less, you will not cause any harm to the patient because of you giving needles to the patient. Okay.
We have another question, doctor, from the Dr. Payne. Hi, doc. The
Hi.
second case is interesting. If we don't patient holistic, we don't see any efficient. You see the gait problem when the patient.
Yeah, the gait is a normal gait actually, but the patient has actually using cane because because of insecurity. The patient is 80 years old, and the patients such as another oldies feel insecure because of instability. Okay, because of muscle weakness, because reduction of proprioceptive and sensibility and vision and hearing that cause imbalance, instability. So the patient has already using cane, but the walking pattern is, yeah, more or less is normal. So the question is, yeah, the gait is quite normal. Yeah, yeah, yeah. The numeric rating scale is only 1, 2, 3. Yeah. So as Dr. Tani said, we must see the patient as a whole. So then we can see the real problem. Okay. Actually, to be honest, why I don't treat the back first, why I treat the knee first, because I see the problems at the knee. I saw the problems at the knee more than the back. That's the first. And the second is, this is old patient. My diagnosis was facet arthropathy, right? So as an interventional physiatrist, I want to do intervention actually, but I must hold it for a moment because I must exclude the red flag. The red flag is R. Fracture means at the vertebral body means there should be no fracture. There should be no osteoporosis because there's osteoporosis, maybe there's compression fracture. Is my red flag. The second, if there's listhesis, okay, because the patients, as we know, once we are getting older, we are suffering spondylosis. Okay, spondylosis means maybe we have slipping of the vertebral bones. If there's slipping of the bones, if then it's unstable, we must refer the patient to the surgeon, orthopedic or spine surgeon. Okay, so I must exclude the fracture, I must exclude the listhesis that is unstable, I must exclude then the cancer because the patient is skinny, and from the second visit, body weight reduction 23 kilograms. Okay, I must exclude the cancer. I must exclude another red flag such as infection. Okay, skinny patients, no appetite, maybe he suffered from spondylitis TB, can be, right? So I do the X-ray first to exclude all the red flags. So I treat the knee first. So the patient was saved by the bell because I don't want to treat the back because I must exclude the red flag first. So I treat the knee pain. I treat the knee pain, then the back pain diminished. Okay. So if we are doctors, we do the art, right? Yeah, sometimes we are lucky, sometimes we are clever. We must combine the luckiness and the smartness. Okay. Okay.
Is there any question?
Any other question?
We have around 2 minutes.
Okay. We have 2 minutes left.
Oh, there is a question. What about the back pain? Should we evaluate the facet problem later? Because after 1 week of treatment, pain from the facet is gone.
Okay. Very good question. The back pain. Okay. Should we evaluate the facet problem later on? The patient has already facet problem and the diagnosis is still facet arthropathy. The diagnosis is still there all the time. Will not be not there anymore because the osteophyte is there. Once we have knee OA, we will be having knee OA for the whole life. But the problem is there pain or not? Hopefully, there is no pain. So the facet is there, the facet atrophy is there. It is a diagnosis, but the pain is no known at the patient. Means that the diagnosis is facet arthropathy, the diagnosis is knee osteoarthritis, but no need to be treated because it is painless, no symptom. Okay.
Next question from the Prof. Fauzia. On the average, how long you spend the time to find the real diagnostic?
Okay, Prof. Fauzia. How long? I want to make it shorter, much shorter. But then, how can we make it too short if we have 80 years old patient or very cerewet? What is cerewet? Too much talk patients, or the patient is depressed. That's why actually we need psychologists. We need neurologists. We need orthopedists all together at our clinics. So then if it's not our problem, it's not our work, I can refer the patients to him or to her. But for then if the patient is mine, I can treat the patients. More or less, I need for the simple case 1 minute. Yeah, doc, I have suffering this. The pain is here. Okay, can you do this? Okay, 1 minute. This is the queer pain. Okay, 1 minute. But if the low back pain, chronic low back pain, 51 years suffering from low back pain, I must spend more time to know the diagnosis. But if you're a GP, if you're a general practitioner that you cannot treat the patient using interventional pain management, you don't need to think too much. Just exclude the red flag, then you treat the patient either using the dry needling, the rehab. If you know a bit about the rehab, although you are not rehab doctor, you can do it. And then you write down the prescription only by asking the patient how much is the severity of the pain, how long, then you treat it. All needed is the step ladder pain management, right? If the fast score is more than 3, you can start using the paracetamol or NSAID, meloxicam, even piroxicam or diclofenac or celecoxib, anything. If we have time, we will talk about the pharmacological treatment. In the next pain management network course, there will be talk about the medicamentous treatment. Okay, so depends on what are we going to give the patient. If we want to give the patient interventional pain management treatment, means we must have the sharper diagnosis because we are going to give interventional pain management to the certain structure. For example, at the lower back, are we going to give the injection to the facet or to the foramen or into the disc or into the nerve or into the what other structure or into the sacroiliac or to the piriformis? So I must evaluate, I must do history taking, physical examinations more than if I want to give just rehab or pharmacological treatment. If you are rehab, of course you need a lot more time to assure that you want to give exercise to certain muscle. Way easier to give medicamentous treatment. 5 minutes is enough, maybe. If we cannot treat it, you know where to refer. To the rehab, to me, or to the orthopedist. Okay.
And then from Dr. Penny. So the diagnosis is facet arthropathy, but no need treatment.
No need. There's no more pain. No need. But there is treatment. There is treatment. Proper body mechanics. Okay, exercise. That's treatment. That's treatment. I always tell my patient, your medication is your exercise. Your medication is your habit. Your medication is your change of your lifestyle. Your medication is your prevention. Your medication is your promotion. That's your medication. So we must change the mindset of our patient that treatment is not always medication.
I think the time is up, Mr. Modi. Okay. Thank you, Dr. Novy, for the great
Most welcome.
presentation.
Hope it is useful.
Yes, hopefully it can useful into our practice, daily practice. And then thank you for all for watching the webinar. If you missed the other session, you can see the recorded on the YouTube of the Pain Management Network. Goodbye, all. Assalamualaikum warahmatullahi wabarakatuh.
Good night, everybody. See you later. Bye.